Cardiovascular diseases remain the leading cause of morbidity and mortality worldwide, with a disproportionate burden observed among older adults. As global life expectancy continues to increase, population aging has emerged as a major public health challenge, intensifying the impact of age-related cardiovascular disorders on healthcare systems and societies. Understanding why cardiovascular disease prevalence rises markedly with advancing age is therefore of critical scientific and clinical importance. Aging is not merely a chronological process but a complex biological phenomenon characterized by progressive structural, functional, and molecular changes across multiple organ systems, particularly the cardiovascular system. These changes interact with long-term exposure to metabolic risk factors, lifestyle behaviors, and environmental influences, leading to the gradual development and clinical manifestation of cardiovascular pathology in later life. From a research perspective, cardiovascular disease in the elderly should be viewed as the cumulative outcome of lifelong physiological stressors rather than an isolated condition arising in old age. This article aims to examine the key mechanisms underlying the increased susceptibility of older adults to cardiovascular disease, focusing on biological aging, atherosclerosis, chronic comorbidities, lifestyle-related exposures, and the decline in adaptive and repair capacities of the cardiovascular system. By synthesizing current biological and epidemiological insights, this discussion seeks to provide a comprehensive framework for understanding cardiovascular disease in aging populations, thereby informing prevention strategies and guiding future research directions. Biological aging of the cardiovascular system. Biological aging induces profound structural and functional alterations in the cardiovascular system that significantly increase disease susceptibility. One of the most prominent changes is arterial stiffening, driven by elastin degradation, increased collagen cross-linking, and progressive vascular calcification. These processes reduce arterial compliance, resulting in elevated systolic blood pressure and increased pulse pressure, both of which are strong predictors of cardiovascular morbidity. At the myocardial level, aging is associated with left ventricular hypertrophy, reduced diastolic relaxation, and diminished responsiveness to beta-adrenergic stimulation. Additionally, degenerative changes in cardiac valves, particularly aortic valve sclerosis, and fibrosis of the cardiac conduction system contribute to valvular heart disease and age-related arrhythmias such as atrial fibrillation. Collectively, these age-dependent alterations compromise cardiovascular efficiency and reserve capacity. Progressive atherosclerosis. Atherosclerosis represents a lifelong, progressive inflammatory disease that becomes clinically significant in older age. With prolonged exposure to circulating lipids and inflammatory stimuli, endothelial dysfunction develops, facilitating the infiltration of low-density lipoprotein, LDL, cholesterol into the arterial wall. This initiates plaque formation characterized by lipid cores, fibrous caps, and calcification. In elderly individuals, plaques tend to be more calcified and unstable, increasing the risk of plaque rupture and thrombotic events. Moreover, age-related impairment in vascular repair mechanisms exacerbates plaque progression. As a result, atherosclerosis serves as the pathological foundation for coronary artery disease, ischemic stroke, and peripheral arterial disease in aging populations. Accumulation of chronic comorbidities. The prevalence of chronic comorbidities increases substantially with age, exerting synergistic effects on cardiovascular risk. Hypertension induces chronic mechanical stress on the vascular wall, while diabetes mellitus promotes glycation end products, oxidative stress, and microvascular damage. Dyslipidemia further accelerates lipid deposition and inflammatory activation within arterial tissue. Importantly, the long duration of these conditions, not merely their presence, plays a critical role in cardiovascular deterioration. Decades of subclinical damage accumulate, eventually surpassing compensatory mechanisms and manifesting as overt cardiovascular disease in later life. decline in physical activity and functional capacity. Aging is frequently associated with reduced physical activity due to musculoskeletal decline, chronic illness, and functional limitations. Physical inactivity contributes to decreased endothelial nitric oxide production, impaired glucose metabolism, and reduced cardiac efficiency. Over time, this leads to sarcopenia, increased adiposity, and worsening cardiovascular risk profiles. From a mechanistic standpoint, regular physical activity acts as a protective stimulus for vascular and cardiac health. Its absence accelerates age-related cardiovascular deterioration. Cumulative lifestyle and environmental exposures. Cardiovascular disease in the elderly reflects cumulative exposure to adverse lifestyle and environmental factors across the lifespan. Long-term smoking causes persistent endothelial injury and oxidative stress, while unhealthy diets rich in salt and saturated fats promote hypertension and dyslipidemia. Chronic psychosocial stress further activates neuroendocrine pathways that adversely affect cardiovascular regulation. The effects of these exposures are often subclinical for many years but converge in later life, contributing to disease onset and progression. Reduced repair and adaptive capacity. Aging is accompanied by a progressive decline in cellular repair mechanisms, stem cell function, and anti-inflammatory signaling pathways. Endothelial progenitor cell availability decreases, limiting vascular regeneration. Simultaneously, chronic low-grade inflammation perpetuates tissue damage and impairs healing responses. Consequently, older adults exhibit reduced resilience to cardiovascular insults and poorer recovery following ischemic or hemodynamic stress. Lifestyle modification remains the cornerstone of cardiovascular disease prevention, even in advanced age. Evidence consistently demonstrates that smoking cessation significantly reduces cardiovascular risk regardless of the duration of prior exposure. Dietary interventions emphasizing reduced sodium intake, limited saturated and trans fats, and increased consumption of fruits, vegetables, whole grains, and unsaturated fats contribute to improved blood pressure control and lipid profiles. Regular physical activity tailored to functional capacity, such as moderate-intensity aerobic exercise, resistance training, and balance exercises, enhances endothelial function, improves insulin sensitivity, and preserves cardiovascular reserve. Importantly, interventions should be individualized to minimize injury risk and maximize adherence. Early identification and optimal management of cardiovascular risk factors are critical in aging populations. Routine screening for hypertension, diabetes mellitus, dyslipidemia, and atrial fibrillation enables timely intervention before irreversible damage occurs. Blood pressure, glycemic control, and lipid targets should be adapted to the individual's overall health status, frailty level, and comorbidity burden. Pharmacological therapy, when indicated, should follow evidence-based guidelines while carefully considering age-related changes in pharmacokinetics and pharmacodynamics. Polypharmacy and drug-drug interactions must be actively monitored. A life course approach to cardiovascular prevention is essential to reduce disease burden in later life. Public health strategies promoting healthy aging, including education, community-based physical activity programs, and accessible preventive healthcare, can substantially mitigate cardiovascular risk at the population level. Integrated healthcare models that combine cardiovascular prevention with geriatric assessment, nutritional counseling, and mental health support are particularly effective in elderly populations. Such models emphasize functional preservation, quality of life, and long-term risk reduction rather than disease-specific outcomes alone. Preventing cardiovascular disease in older adults requires a comprehensive and integrated approach that combines healthy lifestyle modification, early identification and control of cardiovascular risk factors, and healthcare strategies tailored to the aging population. Substantial scientific evidence demonstrates that even in later life, well-designed, evidence-based preventive interventions can delay disease progression, reduce complications, and meaningfully improve both longevity and quality of life. To support continued learning and informed health decisions, we encourage readers to subscribe to our channel focused on elderly health and healthy aging.